Dr. Rowley. Welcome. We are going to be spending quite a bit of time together today talking all about neurodiversity, autism, strengths-based approaches. Um, so we're going to get started. I just want to orient a little bit to what the structure of today is going to look like. So it's 4 hours. The first quarter or third or so is going to be discussing more of the history and the ethical components of this talk, as there's, one ethics CE. Um, we have a few case examples that we're going to discuss in small groups. We'll do breakout rooms and kind of share amongst the larger group as well. We have polls for participation. So I'm hoping today will be pretty engaging and also not just 4 straight hours of me talking at you. Nobody wants that. So we'll have some variety in the day today. And we will have a short break about halfway through-ish this talk. So that would be roughly 11 o'clock Mountain Time. We'll take it because I said it's a long time to just be in here, but obviously take care of your needs as needed. A little bit about me. Why am I talking to you about this? I'm the Assessment and Testing Program Director here at Utah Center for Evidence-Based Treatment. I'm a licensed clinical psychologist. Assessment is my specialty, particularly autism, mostly through the lifespan. Do a lot of work with adults and late diagnosed presentations. And then in terms of my own background, I wanted to address this partly because of the research and the work from advocacy, as we'll get into, really highlights the importance of the autistic perspective. And there were actually several audience members that asked a question similar to this of like, do I identify as autistic, or like, is that my background? And that's not a simple answer, I guess, is the short answer. I have several immediate family members, parents and siblings that are diagnosed with autism, and maybe, and I don't know. Not officially, and yet we'll see. So possibly is the answer to that question. Just to give more context there. But talking about this was really important to me from a values place of wanting to just share this with other professionals. Usually these talks are kind of just developed based on like something I'm interested in, and then I do all this research, and then I'm like, maybe other people are interested too. And I'm hoping we can have some good discussion today. So thanks for being here. And because we're going to be here discussing for a while, I also want to hear a little bit more about who's here today. So throughout this presentation, I'll be using Slido, which is a way to participate in polls or questions. So it's done through this either QR code or this hyperlink you could click on for the Slido for this presentation. And I'll be asking, the broad question is, what are you hoping to learn today? But if you would like, also share kind of like, what's your practice setting, or what's your expertise or license, or what's your experience working with this population, whatever you want to share. So I'm going to open that poll, and your responses will kind of just like pop up as we get them. So let's take a few minutes, and if you would like, just share a little bit about yourselves today. Mm, I'm not seeing much responses. So just let's see if we could try to get this working. Oopsie. Hmm. A lot of people are putting it in the chat. Okay, now we have people typing in the Slido. Okay, the chat or the Slido, either way, that works. So we have people sharing insights about the autistic perspective, information on neurodiversity, no expectations, just like to learn. Great. Keep expectations low, under promise, over deliver. Love it. Identify those on the spectrum with better clarity. And yeah, you can use the QR code or type it in here. Improving clinical work. Let's see, the balance of respecting need for isolation to recharge battery versus isolation that is negative and more depression leaning. Yeah. So we'll kind of get into that discussion a little bit with burnout as well. Awesome. Alrighty. Thanks for sharing. For some reason, I was having a hard time seeing those results on the Slido, so maybe we'll just try using the chat today. Sorry for that. But thank you guys for your contributions. And these are our learning objectives, officially official, and they'll be used in our program evaluations. So we're going to discuss neurodiversity affirming principles and professional ethics. We're going to talk about strengths-based language and how to conceptualize cases. We have ways to enhance the relationship using neurodiversity affirming principles, and some skills to incorporate in our evidence-based treatments. And not all, well, some that would cut across probably all of them, and then some EBTs I talk about more in depth as well. Plus more stuff that I thought was interesting. So also we have our official disclosures and risk statements, no conflict of interest, professional ethics. So the primary people that tend to register for these talks are psychologists and social work. So those are the codes that we'll be referencing specifically. However, in other contexts or talks, I've also referenced the codes for clinical mental health counseling and marriage and family therapy. And there's a lot of overlap, and those two tend to be less specific. So they should all kind of apply, but obviously be mindful of your own professional ethical codes in the areas in which they may differ. And just keep in mind that research or skills might not apply to all populations, and we'll note those limitations, especially when we're entering discussions more about intersectionality. That will be very important. So I'll try to note that as well when I'm discussing the research. Okay. A bit of a history lesson. So let's define some terms because there's a lot of words out there and descriptors. And actually, it's really hard to define all these things and where did they come from and who made them and is it consensus in the community versus actual like peer-reviewed research versus like some person making a blog post, or I don't know. There's a lot actually out there that was confusing. I thought it was straightforward and then I was researching and I was like, this is not very straightforward. So here's like the best of what I can streamline and compile together for you guys. Neurodiversity reflex is a term that just describes people's brains are different. There's natural variation in human ways of experiencing and interacting with the world. That term was coined by Judy Singer, who is a sociologist, herself, I think, autistic or might be ish, or she kind of has maybe a similar stance to me that's like maybe, but not officially. So this was back in 1988 when this was first coined. It was kind of part of a larger, more political activist movement for disability rights at the time. And then it branched off in its own area. And then also kind of like parallel, there was a journalist of The Atlantic that described neurodiversity in an article. I like kind of read the article. It was about like geek culture in the 90s. So that's where these terms come from. It's just the portmanteau of neurological diversity. And the concept itself is not embedded with a certain aim or a certain stance. It's just like, yes, here's what we know to be true. All of these things are different. Then we have neurodivergence, or sometimes abbreviated as ND, which is a neurodivergent person is having a mind that functions in a way that is different from a societal norm. So this gets more into a sociological like construct of like we have certain expectations of what it should be like, and then maybe this is different. Autism is under the umbrella of neurodivergence, but is not the only form of neurodivergence, and they're not synonymous. So someone could be neurodivergent but not autistic. So if you're really describing an autistic person, you really should use the word autistic and not neurodivergent, unless you know they might identify with multiple neurodivergence and prefer that term or whatever. So it's we'll get kind of into identification, but there also is no consensus of what is considered neurodivergent or not. So we kind of know autism and like ADHD, learning disability. So there's this camp of like more biological or innate or genetic variations that fall in this category. Intellectual disability, certain genetic disorders. And then there's a camp of like alterations in brain functioning from an environmental lens. And that causes neurodivergence. So things like trauma, long-term substance use, that could also present as neurodivergence. So, and these are some writings from a academic called Nick Walker, which I'll talk more about them soon. But the term neurodivergence was coined by an autistic activist. I'm going to mispronounce his name. Castian. That's their name. I forgot to look up the actual pronunciation, so I apologize about that. But that is who developed this term. So the then kind of counter to neurodivergence would be neurotypical. This, no one knows who made this term up. It's just out there. Some people cite autistic advocates broadly in the 90s. So it was a way for autistic people to kind of differentiate, you know, like almost an us versus them, the way that society expects a person should typically function or think. That's neurotypical or NT. Again, neurotypical is not synonymous with, you know, autistic versus neurotypical. Like, it's more neurotypical versus neurodivergent. Then there's the neurodiversity paradigm, and this is more of a perspective slash potential aim slash lens that these principles are now pushed through, or these like facts of like things are different, and then there's societal expectations based on those differences. And now here's what we observe some of the interactions. So Dr. Nick Walker is an autistic activist, academic, describes herself as queer, trans feminine. Um, there's no research-based consensus again on like what is exactly the neurodiversity paradigm, but kind of collectively pulling from sources, Dr. Walker describes it as one, the neurodiversity is natural form of diversity. There's no one normal or right type of brain. And neurodivergent people are marginalized by discrimination, invalidation, and rejection. And this is what contributes to what we view as disability. So that is the lens that a lot of this work then moves on from. And that's a picture of Dr. Walker there. So there then kind of becomes more of a social model of disability, whereas historically the diagnosis of autism follows more of a medical model of our beloved, maybe not so beloved these days, DSM. I didn't even put the criteria in here. I'm like so sick of looking at the criteria. Like we all know the criteria. It's like two main camps of like social communication, repetitive restrictive behaviors, sense development, blah blah blah. Like that's the medical criteria. And it's very deficit based. It's very like impairments and functioning as inherent to this condition. And so the neurodiversity perspective really highlights that autistic people can succeed when the environment matches their needs. And so if there's this mismatch, either like invalidation or non-acceptance from people around them, or expectations or structures that don't align with strengths and capabilities, like that's where the distress comes from, that's where the disability comes from, that's where the quote unquote impairments come from. And so social model really emphasizes the need for accommodations, as well as inclusion of autistic people kind of having a seat at the table and developing in research, in policy making, and making these decisions of what is considered even like a good outcome in research, which we'll get into when we talk about evidence-based treatment. And then there's a strong opposition to intervention that makes autistic people act less autistic and ignoring strengths and acceptances of differences. And so a lot of treatments for autism, quote unquote, would be not supported, but through this lens. We touch on ABA a little bit later. That's like a whole other, that could be its own workshop itself, is like the discussion of ABA. But you could kind of start to see how like there might be some things that we do in evidence-based practice where that is a proponent that we have to look at maybe through a different lens than just here's what the research says as an intervention versus, well, who was this for and who developed these outcomes and who was all included, and that would be the social model. But alongside that as well, there's some strong proponents that autism is not a disorder. So arguing almost like analogous with other forms of identity, like ethnic minority status or gender sexuality minority status. Like it's just an aspect of who a person is. And for example, we used to consider homosexuality a disorder. We no longer do. And therefore, people argue, well, neither should autism. And it's like being gay or Black or being left-handed. And like interventions for this in particular is unethical or wrong or not affirming. And the only harm associated with autism is that which results from discrimination. So that's a pretty like strong stance. That really goes against our like diagnostic model. So we can start to see where the ethical dilemmas are arising. Then we have some arguments that are like, well, what about more profound or severe, or like however you want to describe it, cases? From this Hughes article that kind of discusses heterogeneity in autism, there's more severe manifestations of communication, sensory difficulties that remain significantly disabling, even if all possible forms of support have been provided. So even if you have all of the accommodations and the acceptance and support, there's disability. For some people, for some groups, it can be inherently disabling. So there's some critique about neurodiversity movements or autistic rights advocacy that argue the focus is only on, verbal autistic people, or what would used to be considered, high functioning, and that like they're really trying to separate themselves out from quote unquote low functioning, and therefore it's not really advocating for the whole group, or the heterogeneity makes that hard to say what would work for an entire group or not, or defining it or not. So we could see how it gets a bit complex with that aim. So neurodiverse affirming principles, I tend to follow a more nuanced approach between these two. So, classical dialectic. I'm a DBT therapist, so I'm like, yes, the synthesis of the two opposing true things. That's more a relational or interactional model. So disability is an interaction of internal and contextual factors. So there might be some aspects or some individuals in this group, or some traits or some characteristics or some experiences that could be inherently disabling or vulnerable, and depending on the fit with that environment, manifest in different ways. So we don't want to ignore either side, essentially. Like you want to look at both what that individual brings to the table and then their environment. And the benefit of the neurodiverse paradigm is that it really provides that foil to the medical model, so that we can maybe more easily form a synthesis if they're like over here, like, no, it's socially constructed, and no, this is deficit. Maybe like that helps balance it together. And it's case by case. And so we could recognize the importance of social factors in determining the impact of autistic traits without denying that they may sometimes be intrinsically disadvantageous is what the article quoted. That's not my word. That's why I can't say it. Okay. We love balance. We love dialectics. The other critical component of disability or impairment stems from co-occurring mental and physical health conditions. So primarily in individuals with autism that are, or autistic individuals, I should say, that are later diagnosed and have been, not identified early on and quote unquote high functioning in certain circles, there tends to be a high amount of psychiatric comorbidities, even in diagnosed people as well, just because of that, again, mismatch.
Will reverse you up to the limits of your plan.
Oh, sorry. Don't forget to keep yourselves muted. Thank you. Lost my train of thought. I was going to come back. Comorbidities, because of the interactions of the environment, individual, mismatch, potentially. So we know that there's a high amount of comorbidities of various conditions in an autistic population compared to a neurotypical or non-autistic population. ADHD, they're often friends, learning disabilities, social anxiety, which makes sense given social interactions can be very hard and invalidating. OCD, trauma, and PTSD. And sometimes this trauma comes from the autistic experience itself, and sometimes trauma in the sense of autism can make you more vulnerable to victimization. Um, Substance abuse is higher in this population. Bipolar disorder, pretty much anything. But these are the ones. Oh, I think I forgot on here to add eating disorders. That's another very big one. And then there was a specific question from the audience about what is that connection between autism and eating disorders. And that one I think has several layers. One is if you think about avoidant restrictive food intake disorder, or RFID, which is more fear-based and avoidance-based of food, that comes from sensory aversions or sensory experiences related to food, textures, taste, smells, and then like the continued avoidance of them. There also is research supporting um, autistic girls or assigned female at birth individuals really taking literal interpretations about like body image and standards in society and in the media, and kind of some conclusions of like, well, I must have to look this way or be this way to fit in better, as almost like a extreme form of masking. um so there's that with more of our kind of classic anorexia, bulimia presentations. And then there's sometimes a fixed interest on fitness or health or wellness or nutrition, and having a optimum way of eating or dieting, and that then spiraling to a more disordered place, like more of that orthorexia spectrum. So that is also a big comorbidity in this population as well. And there's a question from the audience: current research regarding link between early childhood infection and development of autism and our learning disability. Um, no, we do talk in a second. We're going to talk a little bit about medical comorbidities, but yeah, if you think about like pandas, things like that, there is kind of a connection, but I don't go super into it. So, in addition to the psychiatric comorbidities, there's a lot of medical comorbidities with autism. We see higher presentations of autoimmune disorders, connective tissue disorders like Ehlers-Danlos, gastrointestinal problems, POTS, fibro and chronic fatigue, endometriosis, mast cell activation. As you can see, these are all like very like chronic health conditions. Why this is, I think, is still being developed in research. There's evidence for, again, more of this like genetic variation that can be connected. There's evidence to suggest like a hyper um, immune like in chronic inflammation, essentially like hyperimmune response, that can come from sensory overwhelm, that can come from, again, like chronic trauma experiences. We know that trauma is often associated with medical comorbidities. And so again, if you have an autistic person in an environment that doesn't align for them, and then is like constantly overfunctioning or like being invalidated in an environment, then we could see that having medical impact. So the reason why I want to highlight this is, one, it affects also from like a disability lens, that like oftentimes an autistic person has multiple disabilities potentially. And so we want to be mindful of that when developing interventions, when asking our assessment questions. We want to get into chronic health. There's also challenges just interacting with healthcare systems. So not only do they have these medical comorbidities, they also have challenges accessing the care that they need. And so then it just becomes more of a vicious cycle of things getting worse. So it's really important in our interactions with them, even though most of us probably don't specialize in these particular medical conditions. I don't know if any of you out there are like medical doctors or nurses or whoever. But I'm not. And I still try to ask these questions and get a sense of like, what are your interactions with the healthcare system and how do you get your needs met in these ways as well, and not just related to autism or mental health. Identity first language is another component of neurodiversity. I think you heard me earlier correct myself because I said individual with autism and it's autistic person. So there's no consensus per usual, no like agreed upon definition. Based on like survey research, based on again work of more academics or advocates, people prefer identity first language, arguing that you like can't separate out autism from a person, like it's truly just embedded in how they view and interact with the world. It is an identity, um, and therefore autistic person makes more sense. And then separating it out just is more, they argue, the group who like really advocates for this, that's more on the ableist side. So, however, there are cultural considerations with this as well. I was reading an article that describes how, again, we'll kind of get into intersectionality a little bit, but people that don't have English as a first language and are interacting with English speaking autistic people, they in their language don't have a word for autistic necessarily. So use, person with language just based on that's how their language talks about it. And then get like negative feedback from the autistic community, like, you can't say it that way. Anyway, so there's some interesting cultural considerations as well. So essentially, it's go with how others refer to themselves, like you say, autistic people. But if that autistic person wants to be like, no, person with, then do that. But usually it's identity first language as a good starting point. And then there's this strong opposition to classifying people as high versus low functioning, which we did remove that in our diagnostic criteria. So good for the DSM. But in terms of like how that's permeated into the larger community, even medical community, that's still like a challenge. So essentially, classifying people in camps of high versus low, one, invalidates support needs for those labeled as high functioning. So even if you could be quote unquote high functioning outwardly to some neurotypical standard, there's could be a lot of need for accommodation, need for support. It also, on the other side, does not acknowledge the strengths of those labeled as low functioning. And so just entering in a space with those expectations or lack thereof, of being able to engage in things in a more independent way, or their perspectives may be ignored. The other point that this author makes is that it interferes with those labeled as high functioning to advocate for those labeled as low functioning. So this is more of a political point in that if we do really separate them into these camps, then advocacy work might only highlight one group and people would think it doesn't apply to the other group, or that they don't have anything in common. They're totally different. So that's kind of an interesting perspective as well. The authors in the article kind of talk about how the ignoring the kind of multi-dimensional nature results on harm on both sides. So even though the stated motivation might be to protect high functioning autistics from stigma associated with disability, it actually creates more stigma by separating them into more groups and makes it more stigmatizing for those in another category. So maybe it came from a good place of wanting to reduce stigma or increase people's view of like, no, they are capable, but all it did was create a more stigmatized, marginalized group within that. So we don't use those terms anymore. Usually the diagnostic criteria goes through support needs, which has its own challenges as well of level 1, level 2, level 3 support needs, but at least gives people some flexibility to move amongst the levels, and could be different levels in different areas, like requiring support here, requiring substantial support here. Um, so allows for more of that that complexity within a person themselves as well. So overall, if we're going to kind of summarize, what is the neurodiverse paradigm or perspective or affirming principles? Person or identity first language, autistic person. Talking about the autism or autism spectrum, not so much using autism spectrum disorder. I would say the caveat to that is if you're talking about if you are talking about the diagnosis specifically, like people argue in a research context to use autism spectrum disorder because they sampled a population with that specific diagnosis. So sometimes that label is used just to demarcate it. They reflect this specific diagnostic criteria. So oftentimes it will be used in a research context still, just for the sake of having operational definition of terms. But in general, outside of that, autism or autism spectrum. Inclusion of autistic viewpoints in research and policy is critically important. Highlighting autistic strengths rather than a deficit focus. Shifting the environment to accommodate needs and having interventions really focus on that. And therapy focusing on comorbidities, whether that be psychiatric or more medical, and self-advocacy versus we're not trying to get rid of autistic traits or make a person less autistic. Those are these key principles that we will kind of go more into. But before that, I have another poll, which again, I don't think the Slido works so much. So maybe just put it in the chat. And then there's a question there, assessment report writing that includes diagnostic labels of disorder. Yes, we will get into assessment in a bit. So put in the chat. Based on this discussion, like I highlighted all these key points. Where is your spidey senses tingling in terms of where can you see some of these ethical dilemmas showing up, or what issues come up for you that you're kind of wondering about when we get into our more like specific, we're going to look at the codes and try to do some ethical problem solving. So you can use the Slido or the chat. Oh, good. This Slido is working now. Yes. Advocating accommodations at work/school when someone is on the autism spectrum but does not meet DSM criteria. Okay. Yeah. So issues of like practicality or functionality of like they need support, and if we're talking about the technical diagnosis, there's principles we have to follow there. Managing communication between MD and therapy. So medication and therapy, pathologizing autistic behaviors, denial of access to services due to focusing too much on strengths. Oh, yeah. So that's a potential conflict too. Inclusion, labeling, how disability is viewed culturally and politically, promoting a strengths-based approach while managing areas of deficits of skills, seeking an autism diagnosis but running into barriers as an adult, assigning female at birth, BIPOC. Yeah, so that's a big one. Helping parents understand how to support their children and advocate for their needs at school, issues with appropriate diagnosing, denying competent communication in order to control behavior. ARFID as an eating disorder instead of autoimmune, celebrating diversity. So, yeah, a lot of you guys are seeing these kind of tensions between strengths versus disability and how this might be interpreted in different systems that everyone has to navigate in. And we don't all have a shared language or a shared understanding across systems, across professions. How can autistic clients have accommodations that are not fueled by ableism? Yeah, from a self advocacy perspective, everyone thinking if they are neurodiverse, they have autism. TikTok, convincing kids they have another diagnosis via misinformation when autism a bit better description. Challenging ableism and not unconsciously colluding with it. Yeah, we'll get into some of that bias. I love it. Um, Obtaining disability services for clients who are externally present, more competent, feeling that they need to prove they are autistic enough. Yep. So it's like we have to argue the deficit model for services, and yet we also want to support strengths. Misinformation on TikTok. All right. That's probably a good smattering. Okay. So some of the ethical tensions described a little bit in the literature and some just based on an overview of the principles are mainly related to principles about avoiding harm, about therapist competence, about justice or social justice, respect for people's rights and dignity, and then ethics when it comes to ethical assessment and diagnosis. So these are some of the cross sections. And then I think you guys identified several other factors that might not necessarily fall nicely under one of these. And so there's probably other principles that we could also look at. So first of all, do no harm. That's explicitly stated in the APA criteria, and it is explicitly stated in the social work the NSW criteria, but they don't have like a principle that's like do no harm. It's kind of like embedded in several other like anti-discrimination is one that stands out to me when it comes to harm or like not going beyond bounds of confidence because of potential harm, which we'll talk about with that. Um, just like an observation of the ethical codes when you kind of compare them, it's really interesting what each professional group chose to like highlight or not. Like the APA code is very much like do not harm or coerce or use your expertise to torture people or like it's very like you have the potential to harm people and don't do it. And don't have inappropriate relationships with your clients. Like that's the main those are the main things. Whereas like social work is like, we want to make the world better for all people and everyone should advocate for people that can't advocate and anti-discrimination. And we live and breathe these principles even outside of work with our clients. Like it's very more holistic. So yeah, it's very just interesting of like how what are the things that people tend to focus on. So APA is very much like do no harm. So we think about through that lens, autistic individuals are at increased risk for being harmed by institutions, by providers, by systems, are harmed, are discriminated against, are marginalized. And so we really don't want to participate in that systematic abuse, essentially. Um, so that tends to be, if we really think about do no harm as like our be all end all of like, this is maybe our top priority, it's sometimes then helpful to cut through some of these like tensional things of like, um, what type of intervention might be effective? or like what types of behavior targets, and thinking about would it cause harm to focus on this or not, or would it cause harm to disclose in a certain setting, or would it cause harm to not get accommodations or do what you have to do to like get accommodations in that setting. um so I like to really start there with like, do our actions cause harm or do they have the potential to cause harm? Competence is another factor, but there's sometimes a tension with incompetence. So both codes really dig into, yes, we want to use careful judgment, have appropriate education, don't do anything outside the bounds of competence. However, when there's like no generally recognized standards in an emerging area of practice or in a specific population where the research is more limited, or like if you maybe are the only provider in a certain context that a person has access to, um, then do your due diligence to obtain more competence by using the research, getting more training, doing more consultation, doing more study, particularly if appropriate mental health services are limited. So when you think about the barriers autistic people face to accessing services, and then thinking about how much of those are neurodiverse affirming services, and then think about like who exists in the community that could serve that function. um, it's critically important to try to reduce those barriers by increasing our competence, hence why we're all here today. So I hope all of us share that lens. Otherwise, what are we doing here? But that is like a big, this is first, like for me, just a kind of the ethical mandate of like why I have certain judgments or like feelings about people who are like, oh, I don't work with autism, or like, oh, I don't know what to do with autism, so I'm just not gonna see them. And you're like, well, I don't know. It feels to me, again, from an identity lens, it's like, would you just not see other identities? Or would you work on cultural competence, get consultation, seek appropriate, right? Like, so it's a personal thing that bothers me. So that's why I think I highlight this more. It's like we all should be more better suited to this group. So justice. There is justice broadly and social justice. So social work criteria focuses a lot on social justice, pursuing social change with and on behalf of vulnerable and oppressed individuals. Um, and then APA has a stance of, all persons should benefit from contributions of psychology and equal quality. And we're not condoning unjust treatment or unjust practices. But it doesn't have the same kind of mandate of like advocacy that social work does, which again is just interesting what people choose to highlight. So, social workers pursue social change. Efforts are focused primarily on issues of poverty, unemployment, discrimination, other forms of social injustice. Activities are designed to promote sensitivity to and acknowledge about oppression and culture and ethnic diversity. Um, Social workers strive to ensure access to needed information, services, and resources, equality of opportunity, and meaningful participation in decision making. So there's a lot to be said for the overlap of neurodiverse affirming principles and that code. For APA, it's more just like, yes, we should all benefit from the contributions. So autistic people should benefit from care as well and equal quality care. We don't condone unjust practices. If we feel like a certain intervention or a certain um, lens of diagnosis or testing could be harmful as well. Rights and dignity. So thinking about people have awareness. There's more like self-determination and autonomy and decision making. APA also has a little note about being aware of and limiting cultural bias, which we'll get into. And social work again has the recognition of kind of the dual responsibility of like clients and broader society. So we'll get into self-determination and autonomy and advocacy, but I think sometimes when it comes to cultural bias, it's through the lens of like maybe autistic people can't make certain decisions, or we don't have a great way of hearing their perspective, or the communication about their perspective doesn't align with our standards of communication. Therefore, they're not given space to have that self-determination. So that's where that ethical mandate comes from. Let's see. Assessment and diagnosis. APA has a lot of code specific to this. Social work does not like specific to this, obviously ones that would translate to this as well, but I think about this a lot as a psychologist that does assessment and diagnosis. So there's these mandates about using the appropriate techniques that are based on evidence of proper application, validity and reliability tested on the population that is relevant to the client that you're working with, and then bias and interpretation. And so I think is the challenging part here. One is we kind of like measures, are our measures like validated on diverse populations? Like, and the short answer is not really. So, not really. Not really. We're not great at doing that. We're trying to be better, but we're not great. So, we think about IQ testing, for instance, like the vast majority of people doing like neuropsych testing or like diagnostic testing for autism in educational settings or medical settings, right? We're going to do a cognitive assessment. We're going to do an IQ measure to get a sense of like where's the cognitive function. And there's a lot of research that shows autistic people have greater variability in their performance. So the confidence intervals are then kind of like wider, like depending on the day, depending on what the sensory experience is like, depending on the environment, depending on other comorbidities, like they could have more drastic variance in performance between tests, performance within tests. And so making interpretations about that is more challenging because we can't compare it to a neurotypical group. So if like, oh, there's a significant split in these areas, that probably is more autistic variance. Or like this one, there don't seem to be any deficits here, but it's kind of low-ish, but maybe like with that wider confidence interval, it could be a lot lower a lot of the time, or it could be a lot higher a lot of the time. So like there's not a great way or guidelines in terms of interpreting that data is one example. Another example that I was researching recently is performance validity tests. And this gets into accuracy of diagnosis of like if a client comes in that is seeking, that seems quite attached to an autism diagnosis, and the fear like that clinicians have about, are they just manipulating their responses or trying to act or be a certain way to get that diagnosis, and how can we test validity of that performance? There really are no validity tests that have been established to demarcate that in an autistic population. Number one. So there really is no test for that. And number two, there's this other underpinning, again, clinical bias of like, why would they be faking it? Or like, what really is the secondary gain? And do we do more harm by, again, participating in a system that tends to be more abusive or invalidating by assuming that they're faking it versus taking, like, validating their perspective? So, performance validity is challenging for a variety of reasons. And then bias and interpretation is also challenging, which we'll confront biases in a minute. But if you kind of assume a person coming in is or isn't autistic based on how they seem to look or act, or based on if they said they went on TikTok or not, or where the referral source is, right? Then obviously that's going to color our judgment. So, with that in mind, we are going to shift a little bit to how we then translate these things into our practice. Oh, a case discussion. Yes. Okay. So we are going to start. I forgot to insert it in here. We're going to start out with a case example. And so I am going to share it in the chat for you guys. So you guys have access to it. There's like a little bit of a description in the slide, but it's kind of long. So I'm going to send you this description. I'm also going to read it aloud for recording purposes, but you can also read it to yourself. And then we're going to split up into our breakout rooms. And I have discussion questions for your breakout rooms about the case. I think what I'm most interested in this phase is like, what are general impressions now that we spent all this time talking about neurodiverse affirming principles, but we haven't talked so much about like how to apply them. This is just almost like a pre-test of like, okay, what are your some initial thoughts, or how might you translate these based on what you know now? And then we might contrast that to at the end of the presentation, does that change? Anyway, so sorry, I got very excited about like pre-post discussion. Okay, here's our first case example. So I shared it in the chat. The file's uploading right now. Okay, so it's a PDF. Case example one. Her name is Sally. This is a case example that is just, it's not my client or a client that we know. It's just out there on the internet of like, here's a case example of autism from the PDA Society. So, and it's written from the first person. So this is from Sally herself, her perspective and thoughts. So Sally is a 40s white cisgender woman who I think also is from the UK, because I remember correcting a lot of spelling in here, or like the word wanted to correct a lot of spelling in here. So it says, I'm a mom with a 5-year-old daughter who is also autistic. I was diagnosed with autism just over 3 years ago when I was in my 40s. I was a middle child. My younger brother was born when I was 7, so I was the youngest child until this point, and my older brother, used to show me up all the time for being stupid and not knowing as much as him. This upset me a lot. In retrospect, I can see that my whole family was probably on the autism spectrum. My stepfather used to have terrifying meltdowns, and my mom used to blame me for triggering them. My older brother was the golden boy and reveled in his superiority over me. I felt worthless and that I was intrinsically bad, but I didn't know what it was I did wrong. I used to enjoy making high-pitched noises and doing other deliberately irritating things to get attention. I have exceptionally clear early memories starting from 6 months of age. I was very fussy with food. A lot of food terrified me. I felt vulnerable that it could harm me. Also, I now realize that I am hypersensitive and many textures and tastes are very unpleasant to me. I was a very imaginative child, as was my older brother. We used to pretend to be animal everything that could magically change into any animals we wanted. I can clearly remember my first moments in the classroom. I took a look around and decided that I wanted the teacher's role. School went very badly for me. I didn't mix well with the other children, though I didn't know why. They used to call me names that were effectively about me not being normal. The closest I came to having aggressive meltdowns was the first thing in the mornings, and I became quite specialized at skipping school as much as possible, first by feigning illness, then by playing truant and forging sick notes. I made one friend when I was 7. She was a year older and used to tell me how to act, which I liked because I didn't know how I was supposed to behave, even though I so wanted to fit in. Like my older brother, she treated me like I was stupid and with little respect, but I didn't think I merited respect, so I put up with it. I craved company and hung around with her as much as I could. We got into shoplifting when I was 8 and got caught. As we got older, my friend and I loved doing wild, reckless, and sometimes illegal things. The law meant little to me. I'd continue to shoplift in compulsive bursts until getting caught twice in 4 days when I was 19. I got a boyfriend when I was 20 who wanted to set up a business selling drugs, and the rave scene exploded around us. I, with my then former boyfriend, became the center of a dynamic social scene. I could only speak to friends from this wide group when I was high. I was too self conscious and anxious to speak to them when I was sober. I became very depressed age 19 when I realized that despite my best efforts, I was still a social outsider. I practically worshiped social groups which I felt excluded from. Their members were like rock stars to me. I had little time for people from other groups. The Groucho Marx quote, "I'd never join a club that would have someone like me as a member," resonated profoundly with me. My fantasy world now had evolved to one in which I was the most revered and valued member of a totally cool social group. In real life, I was chronically lonely and depressed.
That's right.
Oh, mute yourself. Thank you. I got scared of people getting too close and shunned people who might have made perfect companions. I had something like a nervous breakdown. I was extremely poor because I couldn't work. When I tried to work, either as an employee or self employed, I felt driven to flee very quickly because I couldn't cope with the restriction of having to be in one place doing one thing. I did quite well at college, though, after dropping out of several courses and was the first ever student in college, I went to be awarded 100% for Art GCSE. My life followed a pattern of periodic academic courses, which I did mainly because I wanted something to do, but no employment beyond odd bits of freelance, which was all I could cope with. I suffered excruciating bouts of depression. I went to whatever free or cheap counselors I could access on my very low income because I wanted to feel okay and be able to get along effectively with other people. Okay. So the discussion questions, which are also attached to that PDF, is just like if it's very broad. What stands out to you? Do you notice judgments that you have? Like, let's confront some of those. What kind of information do you want? If this person was presenting to you for treatment, what might you ask? And what would be a priority in that first session with Sally for you? Let's talk about clinician bias and assumptions. So this is something from affirmative practice lens that's really important, doing a lot of our own internal work and trying to think about how that could come out in our practice or our engagement with autistic clients. So here are several articles that I kind of pulled from about like what are some of the typical biases and how do we counteract that, or what would be the here's what we want to do instead. There's an article about, what can we do better and what are some common myths we can counter as professionals. So one of them is shifting away from labeling behavior as autistic and really diving into what is the function of this behavior. So it's like if we think about stimming, instead of being like, that's an inappropriate behavior and how do we stop that from happening? Can we think about approaching more with curiosity? What is the underlying need of this behavior? What are the triggers? What tends to happen or how is it reinforced? So the authors kind of argue like there's a tendency to stop thinking once we can attribute a behavior to the label of like, oh, they're doing this because of autism. But what actually is happening is that it's more of a communication, and we shouldn't just focus on like, or at all focus on like stopping or reducing a certain behavior, ones that are not harmful at least. Um, let's think about the underlying reasons for that behavior. Maybe there's a certain way, if it is harmful, to shift it to something that's like less disruptive or stigmatizing. Most approaches now promote more of like acceptance of the behavior and the need underlying it, and only suggest a replacement when a behavior is problematic for the person experiencing it, if that person themselves wants to change that behavior. So that just because they're kind of asking us to like think more deeply about like, why is this behavior here? Another kind of shift in provider bias is that moving away from autism as being a linear, like high, more or less autistic, or a little bit or a lot. This is the fun little graphic I really liked that when we say spectrum, it's not like a number spectrum, it's more of a visual light spectrum. So this was from Lynch is the author, that she writes about autism as a light spectrum and not a gradient spectrum as applied in like a high or low distinction. Autism does not worsen as you move up or down the spectrum. Autism is not one condition, but more of a collection of related neurological conditions that are so intertwined and so impossible to pick apart. Um, there's a rainbow of traits that affect most people on the autism spectrum to varying degrees. So these traits are kind of an amalgamation of pragmatic communication, social awareness, monotropism, information processing, sensory processing, repetitive behaviors, motor differences. And each person has these different degrees of traits or behaviors in each of those categories. So maybe the dominant color palette is different, and skill sets and challenges may differ, but they're not more or less autistic or more or less severe. So you could see in the little colorful penguin picture that like some of them have a little more purple or blue, and some have a little more orange. That's what we mean by a spectrum, not like more or less. Other biases reflect more like theory of mind or empathy. Um, Autistic people do not lack empathy. There is a concept called the double empathy problem that was written by, or really articulated by, a researcher named Milton. Um, Autistic individuals and non-autistic people experience the world differently. That's that neurodiversity. Both groups struggle to empathize with each other. So it's not just that it's not so much like autistic people can't think the way non-autistic people can. It's like neither one, there's barriers to both seeing it from either perspective. But because non-autistic people have more of the societal norm or expectation, the assumption that their way of empathizing is better, then the autistic way is viewed as a deficit. But one could argue, and this is what Milton argues, that autistic people actually gain a greater level of insight into non-autistic society or viewpoints or perspective because of their need to survive and thrive in a neurotypical space. Um, so more of like having to adapt. The autistic people have to think more reflectively about like the neurotypical perspective because there could be potentially harmful consequences if not. And so the autistic people might be actually better at empathizing across that gap compared to neurotypical people who has no like, you know, survival need to think from the autistic perspective, unless maybe they're in a close relationship with someone in some way. So I thought that was an interesting take on the double empathy problem. Social motivation. So this is kind of challenging the assumption that autistic people are uninterested in relationships or don't prefer to interact with others. And sometimes that might be true, but many autistic people form and maintain relationships or want to form and maintain relationships. And the way that we judge or assess motivation is inherently biased. And so, like, eye contact or other nonverbals or signals might be poor indicators of someone's internal motivation. There's also social anxiety that affects appeared motivation because we know that's attached to avoidance. And as much as an autistic person may want to engage and does try to engage, social interaction can be very exhausting and draining depending on the environment or that person or people that they are interacting with. And so there might be a need to take more space or more time away, depending on how much energy that interaction takes. And again, that doesn't reflect motivation for that relationship or interaction. So the authors in this article kind of talk about considering the impact of having different social behaviors and making, unconventional bids for social attention and interaction that are not recognized. Fewer people reach out, fewer interactions are successful, and there are fewer positive learning experiences, which results in the autistic person missing the opportunity to develop um, more skills. This could potentially lead to learned helplessness. And for some autistic individuals who are bullied, these experiences are not just unsuccessful and isolating, but also traumatic. And taken together, one must consider that apparent asocial behavior may be, at least in part, a consequence of being autistic and misunderstood rather than a primary or core symptom, right, or trait. So that our understanding of this as a characteristic might not be intrinsic, but related to the interactions that an autistic person has. Other assumptions or biases come from our measures. So this kind of gets at, I mentioned a little bit but earlier about how like cognitive measures don't really align with our interpretations for autistic people as non-autistic people. Also, kind of thinking about why might an autistic person be variable in their performance, and there's a discussion about different reinforcers in the assessment space. So, for instance, autistic people might not be interested in these types of tasks or interactions. And therefore, that affects the level of energy or motivation they have for that performance. Or they are very overly concerned with performing correctly or doing something correctly. And so that might lead to non response or significantly delayed response. Um, there's some suggestions in this article that talks about what are some of the ways we can adapt the assessment space for kids and adults um, that we might be assessing, autistic kids and adults that we might be assessing for various reasons. So one is the use of visual schedules and allowing some choice and flexibility. So, one, we need to provide parameters of what's like a beginning, a middle, and an end of an assessment, because it does have this kind of like endless feeling of like task upon task upon task. Um, so this author writes, like, we often forget to turn the lens on ourselves and ask how we would feel if we arrived at a conference and we were not provided with an agenda for the day that listed the order of events and how long each one would last, as well as some idea when we'd be allowed breaks and what those breaks might look like. Without this kind of framework on assessment day, any person might feel anxious and struggle with self-regulation, right? So needing more of that parameters or structure or understanding to feel regulated and therefore performing at their best ability. Other times, this author discusses shifting away from standardization because, well, first of all, these measures weren't standardized on specifically autistic populations. So at times, a psychologist or an assessor might have to weigh what value a test score derived in a standardized way will offer compared to a test score gained with information about what the person can do when given extra time or more support for language comprehension to best guide conceptualization and recommendations. So this is particularly important for people who are nonverbal or non-speaking, or have different levels of functional communication. So there's more nonverbal assessment tools, maybe modifying other tasks, maybe observations and qualitative information may be more informative than the numbers themselves for building meaningful understanding and recommendations. And so that could include things like modifying the instructions or extra repetition of instructions or flexibility and testing the limits more, like if they reach a certain cutoff. Um, so it is an interesting ethical question in terms of departing from standardization of like, well, we want to follow the standardization, and what if this wasn't standardized on a population anyway? So why would we follow it if it doesn't seem to apply and seems to inadvertently cause us to misunderstand this population and potentially propagate harmful stereotypes? So this argues that you could deviate from standardization. And I think we do that generally, not just for assessing autistic people. And you could just be clear in like your description in the report of like what you did and why and what were the observations, just so that we could interpret, others could interpret the results in context. So more about assessment. Oh, I think there was a question earlier about like, what do we do about a diagnostic label when writing a report? And so from a neurodiverse affirming perspective, recommendations around that include, having the diagnostic label in terms of like, here's the code and the title for like medical record purposes, insurance reimbursement purpose, um, that yes, we include that in there, and we do a lot of work with the person or the family about what that means, terminology. Here's a neuroaffirming framework, and maybe use autistic or identity first language throughout the report or in our summaries or recommendations, just to orient them a bit more about that. But so it's kind of a balance. It kind of reminds me a little bit about like if we're doing assessments from like a gender affirming standpoint and a person has, a legal name, that's their dead name versus their name, and how we might acknowledge like this is the legal name, but then use their name throughout the assessment and just be like, yes. So the kind of like that is what it reminded me of in the discussion. So hopefully that answers that question. Okay. Barriers in medical systems. So this, again, when we're thinking about provider bias, is a big one. So there are some a lot of assessment related like research related to providers dismissing concerns brought by autistic people, whether that's concerns about like, do I have autism or not? Or like, I am an autistic person, I have these other concerns that I need support with. So it's kind of both. And then resistance to changing intervention approaches to meet needs, different navigating multiple systems. So usually our recommendations would include potentially different professions that we're asking them to interact with, different, medical versus educational versus. So that's challenging when there's like not a shared language and understanding among providers in that way. There's also, we know, co-occurring executive dysfunctions. So if an autistic person is having to like manage all these appointments and talk on the phone when we know sometimes that's really challenging, or communicate in a way that the system is receptive to, when I think everyone struggles with that sometimes, that creates more additional barriers as well. And then there's a lot of documented descriptions of people refusing service to this population, which is awful, but can happen as well. So it creates a lot of trauma from interacting with systems. So potentially by the time they get to us, there's all of this history of being dismissed or discriminated against. Um, and so we have to come from the lens of like, some of their interactions with us might be informed by that and maybe not about us particularly. And another provider bias comes from people who self identify as autistic or self diagnose. I won't go super far into this. I did like a whole talk about self diagnosis, which is why. So I'm like, there it is that. But yeah, it's on YouTube if you ever want to watch it. But this is the neuroaffirming lens to self identification. According to this, here's one of the articles here, and there's a couple others that I've cited before, but generally accepted, it's generally accepted in the autistic community to self identify. Like, fewer autistic people believe that you need to have a quote unquote like official label, or don't, in order to like identify, engage with the community. Um, there's a lot of barriers to formal evaluation, including provider bias. So even if you do manage to find a place and have insurance or can afford it, a provider could just choose not to, or be like, I don't do that. And there's potential risks to having the official diagnosis on record. I kind of noted some of these, like in one state, I think it's North Dakota, providers are required to submit confidential patient information to like a statewide registry of like everyone who's diagnosed with autism. They just like have this database and they can't opt out of it. So that's odd. And some places, refuse things like, or like more so advocate for like being put in under guardianship or conservatorship as an adult if you're autistic, or refuse things like custody in divorce agreements, visas if you're moving. So there's potential harm that could occur if there is an official diagnosis that plays into this. And some evidence suggests that autistic adult self diagnosis tends to be pretty accurate. And this particular measure was based on people who did the RADS-R, which is a free online screener. And then those results, if they aligned with, greater autism alignment, and then they went to have like formal assessments at some point later and they were officially diagnosed, so like that tended to match based on their performance on that measure. So there's a lot of discourse that says that's pretty accurate, but not a ton of measurement thus far. However, there are risks to self-identification if it is accurate or not, if we think about those comorbidities, especially. So maybe it's not so much about is it autism, but autism and what else, and what types of interventions are going to be most supportive, or how would you access that otherwise. So that is the main risk, but neurodiversity affirming lens would argue could potentially be more harmful to be biased against it than to provide a diagnosis. But that's a perspective. For this lens, I said I talk about that more in depth in a different talk, but this is the neurodiversity affirming lens. So, based on, we also, I'm going to at some after this discussion, we're going to talk about intersectionality. But so thus far, when you think about typical provider biases and typical counters to those provider biases, I really would like us to do more self-reflection around it. Like, do you yourself have any of these biases, or did you at some point? And what was that process challenging that bias? What do you still kind of feel pulled towards, or do you have conflicts between any of these? So that is what I would like us to focus on next. Let's talk a little bit more about intersectionality. And so there, as we know, and it's becoming more aware, that women and assigned female at birth individuals are diagnosed later in life, and there's often potential harmful stereotypes about what autism looks like or doesn't that affects um, those individuals getting a diagnosis or getting support or being validated or acknowledged, due to maybe it's less overt behaviors, higher masking, verbal skill, whatever that may be. There's lots of reasons why. Is that this has been established. I've talked about this a lot in other talks, and it's been established, so I'm not going to spend too much time on it, but we do know that this conflates things as well. When we think about race and socioeconomic status, that affects access to service. Maybe there's language barriers, for instance. There's a lack of culturally tailored information. So, for instance, there's some research that suggests certain what like we might be looking for as characteristics or traits for early diagnosis and identification are not things that certain groups of the population would have like consider a problem or consider concerning. So like eye contact, for instance, depending on the culture you're from, would be expected or not in interactions, or varying degrees, or different types of social communication that from a medical model is deemed inappropriate might be appropriate for that culture. So when we're kind of putting out like here's what traits look like, they're not often accounting for those like variances in different groups, which affects diagnosis or getting appropriate treatment. I talked about this in another talk as well, but also there's like inappropriate, like wrong diagnoses and therefore incorrect treatments. So African American or Black kids are more diagnosed with conduct disorders or oppositionality or um, behavioral related disorders rather than autism when they are autistic, and therefore that's a big mismatch in intervention and identification. And so if you have multiple confluence of these things, whether that's gender, race, SES, as well as sexual minorities or gender minorities that conflates some of these biases. Um, some other research done with LGBTQA plus autistic people observe, like within the autistic population, that there's poor mental and physical health outcomes. There's more co-occurring diagnoses, more unmet healthcare needs, exacerbated suicide risk, and some of the disparities can be mitigated if there's anti-discrimination laws and policies and Medicaid expansion for different groups. So I think that in terms of like addressing our own biases or our own identities, this comes from the Pamela Hayes, Dr. Hayes framework for self-reflection on what are our own aspects of identity and how does that show up in our practice and how might that contrast with those of our clients. She uses the addressing framework to talk about here's all the aspects, or not all, but many of the aspects that can show up. And Dr. Hayes is also doing a CE event next week, next Friday, if you are interested in learning more. But we probably don't have time to do this as a self-reflection exercise today, but it's helpful to think about where you might fall in each of these categories and how some of them you might fall more in a privileged group and some of them you might fall more in a marginalized group, depending on which aspects that you identify with or are part of. And that is true for our clients as well. So maybe if we get like overly focused on one, it kind of overshadows the other, or we don't think about the influence of others. So if we're really focused on autism, but we're not thinking about race, or we're not thinking about gender, or we're not thinking about age, right? Like it affects the relationship, it affects the effectiveness of the interventions as well. So again, the way to kind of do this work from a cultural competence standpoint or from an affirming standpoint is to do this with yourself, to first be aware for yourself, and then also doing this with clients and thinking, having more overt conversations about where identity might differ and what that means for them and what is that important to them or priority, or does it get in the way of treatment, or is it something that can be kind of worked through? So for example, how this might look like in practice. So like I'm in Utah, as many of us are. And in Utah, there's many people part of the Church of Jesus Christ of Latter-day Saints, and I am not. And so sometimes it comes up as like either they are part of that church and I'm not, and so like a different values discussion, or that's the context in which they grew up in. And so even if they're not currently, that is sometimes something that has to be addressed, is like this is the context and how it influences current challenges or viewpoints, or even traumas sometimes. And so not having that background, right, that's like something that has to be discussed as part of session as well. So consider that as like a framework. And there is a formal CE event, I think sponsored by UPA, that Dr. Hayes will do. Okay, in the room, meaning what are some actual affirmative strategies and skills? Now that we have the principles, what do we do? Okay, the first one I want to go over is starting with a sensory-based entry point. This comes from Dr. Montero. She developed the MIGDAS, which is an assessment for autism. And she has this framework of like strengths-based and neurodiverse affirming, and how we might just kind of meet a client where they're at, help them be able to communicate their perspective in the best way possible, and use their words and be a part of their world and shift away from more like judgmental labels and help them kind of just acknowledge the differences in communication and relationships and sensory processing and how that can be a good then jumping off point for intervention. And so the reason I think it applies more broadly than just if you're administering the MIGDAS is if you think about um, a therapy space or just meeting autistic client and how the demands of therapy can sometimes not be aligned with what their strengths are or interests are. We're sitting in a room talking face to face, like about emotions, and like you have to describe these things and share these things in, the questions that we ask or the way we ask them or our spaces. So how can we reduce some of that distress in that space? How can we reduce the urge or the natural tendency to mask when faced in those new situations or in those um, less structured spaces? So sensory based. Oh, sorry, I accidentally no, accidentally went too far. Previous, I was gonna do a little poll. Oh my gosh, this is like not whatever. This is a poll. I'll just open the poll now, but I'll talk more about the sensory-based entry point. But essentially it is like helping autistic people regulate using sensory materials to allow them to then be able to describe their experience in a way that makes sense to them, help feel comfortable in the space, help build a relationship, decrease the need for masking in that space to have more authenticity, more genuine interactions. Or to be able to even like observe that. So so I just had a quick fun poll about like what are your favorite sensory items that you guys use. And I have some here that for show and tell, but someone put in the chat kinetic sand. That one's awesome. So I have this little toy that's like a 3D printed kind of like, it's just like functions almost like slime, except it's just like a plastic thing. Everyone loves it. It's so anyway, I use it all the time during meetings. And then this one is a like, it is kind of squishy, but it's like heavy, like solid, and like it's slow release back. So it's not just like squish, it's like has some oomph. Sequin pillow is another amazing one. I don't have one in this office, but I used to. And that was always a hit. Dogs are awesome. Bilateral tappers, plushies, squish balls, puzzles, blankets, pillows, fidgets, noise machines, Play-Doh, weighted blankets, bracelets, magnets, rings, yeah, jewelry. Yeah, so many fun things. And it's really impactful if you use these things versus not. Like I had a client come in the other day. I was doing a kind of like initial intake with her and her mom. And she came in and she like immediately just like went to these sensory toys and then engaged, I would ask questions and she would answer and it was kind of a good discussion. And mom was like shocked. She was like, she usually never talks to like new people ever. Like or like it's odd. Like it was a new experience for mom for her to just be able to like sit and engage. But she was like so into the mom was like, maybe she's just so distracted by these things, or like she's pretty regulated with the sensory and the movement. And so it's really helpful. I like them myself as well. So if you're in the space, I use them in meetings and everything. So there's also um, hmm, tappers, a lot of you guys shared as well. So, and then some of you guys in the sensory materials also address this component, which is the therapy environment, like literally the room or space you're in or that your client may be in, because also we're in the world of telehealth. But there are a lot of sensory considerations, aversions or preferences or seeking that way to think about as well. So lighting could be very aversive. It's too harsh if it's like fluorescent or loud, which sounds maybe like a strange statement, but electricity makes noise, and autistic clients can often hear certain um, noises. I have this in my house too. There's like one light that's on that I like hear buzzing and I hate it. So I understand. And or like the windows, like do you have the capability to like put blinds on or not or move things around? Seating options was discussed. Oh, also, I did show a picture of it, but there's also this book that I was referencing, which is called A Clinician's Guide to Supporting Autistic Clients. It's a really cool book from Amy Marshall Saidi, just like a collection of research and strategies, some of which we'll touch on today. And so the seating options is kind of important as well as like um, you know, more soft, more firm pillows and cushions or blankets or no? Or do they have the option to move around or no? And there's lots of ways you could adapt it depending on like your own resources or environment. Like you don't have room for multiple seating options. You can again shift it with like pillows or a footstool or whatever. So like I definitely have clients that like either I have these giant pillows in my office and some of them like immediately just like toss it over, like get this out of here, and some are like hug it. So it's like just options. I think that's kind of the key for all of these things, like flexibility in the space so that it could be kind of tailored to people's needs, the ability to have movement, music or sounds, sound machines, like actual music, like playlists that they can select, soft music, and different communicate options. So this is referencing the sometimes you have to make it explicit. Well, oftentimes you have to make it explicit that your clients can choose these things or that these things are for their comfort, because especially again, like high masking autistic clients, they're used to suppressing these behaviors or urges or not wanting to be burdensome to other people or not want to draw attention or like inconvenience other people or whatever. And so you have to be like, no, you can be like, I'm like, do you want this fidget? Do you want this like pick? Or do you like sitting here? Where do you want to sit? Like I kind of let them make that choice, or you just have to communicate that they get to choose the options sometimes because maybe they're not used to being in spaces where they can or are comfortable doing so. And sometimes you might have to continue to reinforce it or consider going outside if possible, like walking around, being in nature when it's nice here. I like to try to do that. So just some flexibility and like other than just like sit in these chairs and stare at each other and just talk. It's nice for me too. Thinking about telehealth, the a lot of times autistic clients might prefer telehealth because they have more control over their space, feel safer in their space, more comfortable. It's a little bit less interpersonally intense. For like eye contact with a camera versus a person, or yeah, just and they less unpredictability about like who else might be around or driving there or so. And then it also kind of allows for multiple communication methods because most telehealth um, platforms have like a chat function. So if there are times in therapy where verbalizing becomes challenging, which can happen, or like shut down or overwhelm, it's nice to have other avenues other than just like having to talk about it. But you can also in the room do things like drawing. So that's a thought there. So other kind of affirming practices is really focusing on kind of autonomy, self-determination. There's um yeah. So when we think about the history of this, oftentimes systems or laws or regulations in with the justification of protecting a vulnerable group end up removing a lot of their rights and autonomy. And so it's important not to do that in the therapy space. So it's kind of reminds me a bit about like if of like the idea law with like educational accommodations or services about putting people in like the least restrictive environment for them to be able to succeed. So like emphasizing self-advocacy and autonomy, and if there's a reason why they truly cannot or would truly benefit from something like a guardianship, then doing that as needed, or really evaluating the pros and cons for that, or involving others in treatment to support that. But again, being extra mindful of self-determination. Um, this also includes, there's like a whole discussion I'm sure we could have about this, but making diagnoses explicit. So we've, I've definitely come across this, I'm sure many of you have, about parents in particular when we're assessing kids or working with kids not wanting to disclose their child's autism diagnosis to that, like not telling the child essentially that they're autistic or maybe being assessed for autism. And so from a neurodiverse affirming perspective, it's very important, essentially like a person, all people who, regardless of how old they are, have a right to that information, and that when we, even if we can't necessarily ask a child client themselves to reflect on this, when we ask autistic adults reflecting back on their childhood experiences, overwhelmingly they indicate that they were always kind of aware they were different, but because they didn't have like an understanding or an acknowledgement of it, it was very much internalized shame and guilt about something bad in themselves. Um, and that overwhelmingly adults reflecting back find that they really benefited from having a diagnosis, from knowing this information. It felt validating. They were able to communicate needs, get those needs met, have more of a sense of community. So it's really important to work with parents to get to a place where disclosing the diagnosis can happen. And obviously, that could be a process because if they have all of these stigmas and negative beliefs about it, then the way they're going to communicate that to their child would potentially be harmful. So it's about kind of like working with the parents on validating their fears, but also some education so that they could come at it from a more neuroaffirming place as well. So that was a very important point, again, from like an ethical standpoint, as well as just experience wise, it's better to tell. Everyone has a right to medical information about themselves, including children. And I think I get into this at some point, but if not, if I'll mention it. So Dr. Liz Angoff, she is a neuropsychologist that has developed a lot of material about like how to give testing feedback to kids to help them understand or help parents understand in a affirming way for a variety of diagnoses, not just autism, but she has some really helpful stuff about autism. And she is giving a talk also this month about neurodiverse affirming assessment with kids. If you are interested in that, I recommend her work. I think I mentioned it later, but I just wanted to make sure. Yeah, she has a website, as people put in the chat. I just want to make sure people were aware in case I forgot to mention it later. Okay. The other important part of it is more so like sharing the diagnosis or with like other people. And what are the pros and cons to disclosure? What are the risk and benefits to disclosure? If you like request accommodations, you're going to have to disclose probably. So if it's not a safe space, then if you're not, like, not doing too bad, like maybe it's fine without accommodations for a while, or sharing with other family members or other important people in your life. Um, Again, like, are they a safe person or not? And just kind of processing with individuals or with families how to make that choice, and then supporting them and how to communicate that. So disclosing can be helpful. Um, and the research kind of shows that, like in an educational setting, this research was done, that kids might be treated differently, even though they're not supposed to be, by teachers or staff if they have their diagnosis disclosed. So you kind of have to weigh that with, like, is that gonna outweigh, not having accommodations versus having accommodations. So it's tricky. There's not a great, I think from an affirmation perspective, it's like openness in general is a value, and a recognition that, like, in certain places with certain people that could cause harm. So you ultimately have to, again, self-determination, leave it up to the person or family, of safety, like to make the choice that feels safest to them. Okay, strengths-based language. Reframing. Okay. So where am I? Have a fun thing. I'm trying to think. Okay. Obviously, the diagnostic criteria and often common descriptors have judgmental labels. And so I there's this kind of article out there in the world. I'm actually going to move a little bit away from my presentation to be able to share this. That's called neurotypical disorder, and frames neurotypical behavior as if it was written in the DSM and what that might feel like. So I'll link it in the chat, but I'm also going to screen share it for people because I think it's just a really interesting thought exercise of, like, how do people feel if this was how your behavior was described. For some reason, I'm having a hard time. Okay, there we go. That's the link to the article, and I will screen share it. So, and this is free source, by the way. Nothing's copyrighted here. It's just kind of like a fun exercise. So, they describe neurotypical disorder, rigid, repetitive patterns of social interaction and comprehension, as like obsession with social banter, interpersonal drama, and politics, fitting in with a specific group and or hierarchy, tendency to partake in herd mentality and behavior, tendency to be easily influenced by their peers and conform unquestioningly to societal expectations, deficits in cultivation of special interests and exploration of innovative, novel thoughts and feelings, difficulty engaging with or seeing meaning in activities. I'm not going to read all these, but just some of these. Failure to comprehend or visualize identities that are not deemed normative, fear or shunning people whose behaviors are not deemed normative or predictable, pigeonhole, stereotype, and categorizing others, rigid adherence to unspoken implicit expectations, emotional withdrawal when those expectations are not met, tendency to use language to say one thing but mean something else. So it's pretty fun. Predictable interests, fixed to linear thinking, diminished attention to detail. So, anywho, I just thought that was an interesting reframe. Um, Let me go back to sharing the actual presentation. Sorry, my computer decided to lose. There we go. Lose where I was for a minute. Okay. Then, so if we reframe this, here's some like common phrases that tend to happen or that tend to be written about or shared. So like poorly modulated eye contact. And instead, we could say something like differences in use of eye contact, including, okay, like behaviorally, what are we describing? Consistently avoiding, fleeting, when speaking, but not so much when listening, odd tone of voice, rigid or and then instead, okay, what do you mean by odd? Because that's not behavioral. So like, is it stilted, exaggerated, lilting, rigid and inflexible? Again, that's more judgmental. What's another way of phrasing that from an affirming lens? Thrives in routine and structure, feels regulated when having a sense of control and predictability in their environment. So we do have another case study. Yes, we have time for this case study. We might not get to our third case study. Sad, sad. But this one is important because I want us to practice. There's a case description that was written. It was a journal article, actually, like a case study. So it's written through from the perspective of a clinician. And so could we look at, so in the small groups, I would like you guys to look at, what aspects of that are strength-based and what aspects of that, like, could part of it be rephrased to be more strengths-based, and what would that look like? Okay, so the case example, the presented patient is a white Caucasian, assigned female at birth. Who visited our clinic at the age of 16.5 years due to depression, gender dysphoria, and suicidal thoughts. At the first meeting, he explained that he was trans male and asked the therapist to use male pronouns. As a toddler, he was described as sensitive, irritable, stubborn, and shy in social interactions. Spontaneous social interactions with his peers have always been scarce. His primary school psychological assessment revealed average but disharmonic intellectual abilities with slower psychomotor speed. Therefore, he received um, educational adjustments during schooling. Occasionally, he was bullied at school for being overweight. He reported not feeling connected with his schoolmates, and he spent most of his time at school alone. When he was 7, his parents divorced, and in this period, his mother noticed he had severe nightmares. They consulted a child and adolescent psychiatrist for advice, but he was not provided with regular treatment. His special interests were fantasy, animals, and robots. He kept some of his childhood rituals He kept some of his childhood rituals. All right. Um, just join your small group then if you're just popping in. Um, Such as using a stopwatch every morning to measure exactly 5 minutes before arising from bed. He never liked proverbs or metaphors because he didn't understand them. To relieve his social anxiety and loneliness, he pretended to be a part of a TV show several times a day. He described himself as a tomboy, always wearing neutral or more masculine clothes. He completed his primary school successfully. He described his sexual orientation as bisexual. However, he hasn't had any intimate relationships yet. At the age of 15, he met a transsexual person and discovered similarities between the two of them. Half a year later, he revealed his feelings of GD to his mother, asked her to use male pronouns, and chose his male name. She promised him support, but believed this was just a developmental phase, and he was not ready to follow his wishes, which made him sad. His GD was particularly focused on his breasts. He didn't mind his regular monthly bleedings since they didn't show. He couldn't talk about his feelings to his schoolmates because he couldn't imagine that their reaction would be supportive. He mentioned his transgender feelings to 2 of his friends, both females, and one of them started using male pronouns and his male name, which positively affected his mood. After his 16th birthday, his mood deteriorated. He reported feelings of depression lasting for several weeks with frequent bouts of crying in the evenings. occasional thoughts of suicide, with 2 episodes of non-suicidal self-injuring by scratching. His social anxiety intensified. He had no history of substance abuse. His biggest wish was a mastectomy. The assessment findings, some um, key descriptors. At the first appointment, he appeared to be a neat, male-looking, overweight teenager with short hair wearing military-colored male clothes. He was alert and oriented. His speech was slow with increased latencies, taking long pauses before answering. His use of language was specific, unusual. He repeatedly mistook the meanings of words and phrases. He avoided using gender-defining pronouns in sentence structure, so the sentences were completely without pronouns. His thought process was logical. There was no evidence of hallucinations or delusions. His affect was mildly depressed and blunted. Although he was seen holding back tears from time to time, he was anxious, reserved, and he described symptoms of social anxiety. He reported suicidal ideations, but was able to agree on an anti-suicide security agreement. He expressed his GD, focusing primarily on his breasts. Some typical characteristics of ASD were evident: difficulties in mutual gaze and in social interactions, language peculiarities, specific interest rituals, which warranted further evaluation. The results on the RADS were above the cutoff score, suggesting the possibility of ASD, which later was confirmed by the ADIR and then by the ADOS classification. Problems with communication, inability to understand metaphoric speech or using idiosyncratic speech, which was less spontaneous and only partially accompanied by nonverbal signs, eye contact, and gesticulation, were evident. Problems with understanding social situations and mentalizing about himself and others were also present. It's hard to be mindful of that. Again, from a training standpoint, like we kind of addressed earlier, is like we're, all of our like templates, and we're used to just having more of that like medical based language in our reports. And so shifting our writing style or our traditional way of doing things takes time and practice. This next section I wanted to address was autistic burnout and how that's pretty important to address with autistic clients. I feel like um, that is often where the dysfunction is happening, particularly for people who are, high masking, um, most of their life quite successful in moving through neurotypical spaces, doing well in school, having relationships, careers, and then there becomes some cliff that they go over, and then that's where more of the challenge comes in. Alrighty. So, autistic burnout was first officially defined, if you want to call it officially defined from a research perspective, in this article by Raymaker and colleagues. And it's important to note that autistic burnout is distinct from occupational burnout or clinical depression. And so there's definitely been a lot of discourse lately about burnout. And so we might have some familiarity about what that is or some experience in what that is. And it's important to note that it is kind of distinct. And it's mainly characterized by chronic exhaustion, loss of skills, and reduced tolerance to stimulus, according to this operational definition. Um, and burnout is happening due to life stressors, the cumulative load experienced, and barriers to support that create an inability to obtain relief from the load. Expectations outweigh abilities pretty chronically. So there's a lot of over functioning. There's negative impact on health, capacity for independent living, quality of life, including suicidal behavior. There's also a lack of empathy from neurotypical people. that can exacerbate these things. And so some potential protective factors include having social support, including formal accommodation, reduce expectations during times of stress, and unmasking is a big one. And usually, in the process of unmasking, burnout becomes more highlighted, or areas of challenge become more highlighted. Um, and so, why does burnout tend to happen for autistic people? Is that one, daily activities are tend to be experienced as more stressful. There's daily stress of navigating routine disruptions, non-autistic social interactions, demands of work and school. There's sensory overload. And then prolonged periods of sensory overload tax nervous system, reduced capacity, and increased likelihood of burnout. Executive function overload. Again, chronically taxing that leads to loss of skills. Um, Navigating social or educational systems that are primarily dominated by more holistic or neurotypical systems. So masking, and then accessing support and accommodations, or lack of accessing support and accommodations, are some of the main traits. So, what do we do about that? But the reason, again, why I want to highlight this is because I feel like almost always, well, again, I'm coming from more of an assessment diagnostic lens as well as a therapy lens, but mostly assessment diagnostic lens. And so usually autistic burnout is what prompts adults to seek a diagnosis of like, okay, maybe I had these thoughts or maybe I've had these wonderings, but I'm fine. You know, I have my family, my job, I'm pretty successful. But then there's a point of like, I can no longer do the things I used to be able to do. And now it's really distressing. And now I'm really overwhelmed. And now maybe I have this history of sensory challenges, but now I feel it much more acutely. And like, why can't I just do the things I used to be able to do all the time? And so, um, oh, sorry, I was catching up. There was like a lot of comments in the chat from the last discussion. But anyway, so and so when they come for an evaluation or for therapy, that they're in the midst of burnout, and maybe that's the case for you all as well. So that's just, or just something we need to be attuned to and thinking about. It also impacts, oh my goodness, sorry, it also impacts diagnosis. Or if we think about like what is the developmental process of these behaviors, of like, well, these weren't really present or a problem until now, so is it developmental? And it's like, well, maybe it's because of a chronic period of overfunctioning. And yes, of course it wouldn't be problematic until now, because now pandemic was a big, I think, push related to autistic burnout, or coming back from the pandemic. Because maybe autistic people were like, cool, social distancing and remote work, perfect, and then had to come back, right? After that expectation was no longer in place. So um, that's why I feel like it's more present now and more in the discourse now, and research is emerging now, and therefore I feel like it's very important for us to be attuned to. So then, how do you support a client in coping with autistic burnout? um, Burnout recovery, this is through the lens of a clinician. The post or the label, it's cited in here in the handouts, but I just want to make sure I get the name right. I think it's neurodiverse insights. But there's conceptualizing of like, there's immediate burnout, and then there's sustainability over time to kind of have more long-term recovery and prevent it in the future. So those are kind of the two aspects. So if we're in immediate, again, my DBT brain is like distress tolerance, like how do we just get through and survive without making it worse? There's sensory soothing practices, reducing sensory input in general, lots of sleep, lots of rest, maybe engage in having comfort foods, or say foods that we're having over and over again. And the time spent with interests that feel, again, safe or rejuvenating. Neurodivergent insights, that's where this comes from. Sorry, this is where I cited it. So this is the priority again for in terms of getting through immediate recovery, or um, we're really in the thick of it and just need to kind of like start somewhere. Longer term, there's several lenses of like, here's how we make a plan, and they all kind of hit on roughly the same thing. Here's the one from the original article, Rainmaker. One is to advocate for formal accommodations in your spaces, have some time off or scheduled regular time off and breaks when possible, reduce activities in general, and ask for help more. Like regularly, like not just temporary reduction of activities, but actually like maybe reduce them as like your main responsibilities. Recognize triggers and cope ahead for times we know that stress is going to be higher or there's going to be more taxing on our resources, and engaging with the autistic community. So having a really validating space, and maybe learning from each other and about like what works for them or doesn't. And so other burnout recovery plans include practicing boundaries and dropping unnecessary demands. So supporting clients and like setting those boundaries with others. And, again, DBT for me is like do a dear man and say, assert or say no. Um, breaks, finding alternative ways to express yourself. So whether that's journaling, art, differently creative outlets. One important component in this lens is not letting routine go. Like, yes, we want to reduce expectations, and yes, we want to reduce activities, but like don't just like remove all routine, like have some supportive structure. Routines are soothing to nervous systems because you know what to expect, and it reduces like decision fatigue. So anytime you can kind of remove some decision making from your plate, that's nice. So it doesn't have to be like a strict or rigorous routine, but like a gentle routine. Body movement, spending time in nature. Again, that kind of taps into sensory as well. Um, Unmasking, what does that look like? I think again, there's no, for all these, there's no research consensus. Um, there's some general principles that seem aligned. One is to stim on purpose. So if you had like previously been masking, like suppressing those behaviors, what would it be like to do that more intentionally and then maybe reacclimate to using that as regulation? But practice stimming that maybe used to happen, or urges that used to happen, spending more time alone. So if you think about what does it look like to unmask, have clients envision or actually experience of like, well, how are you like by yourself if you don't have like any expectation from other people or have to perform for other people? What does time alone look like, and can you act the same way with others that you do alone? Or conversely, what behaviors do you specifically do for other people? Like, what do you only do around people or certain people? Rediscovering interests. So I kind of touched on this with burnout recovery, but this one had an interesting lens where it was like, what about interests from when you were younger? Like maybe you had interests that used to be really regulating and engaging for you, but for some reason there were judgments about that interest from others or yourself of like you shouldn't be interested in that anymore. Like maybe you're too old for that, or it's a bit juvenile. And maybe you go back to the things, whether that's the activities, the shows, the music that you used to really enjoy and find solace in, and see if that sparks something. And community is another important part of unmasking. So having safe people to unmask around, people that won't be judgmental, people that will be understanding, whether that's people, loved ones in your life, and or other autistic folks that you try to connect with. That's another important part of unmasking. And Unmasking might present some initial challenges of like if you're letting go of these compensatory strategies, um, it highlights things that were avoided. So it's also acknowledging that it might feel harder for a little bit until we move through burnout recovery. Or like relationships with others might change because you might have acted a certain way to accommodate others. And then when you're not, then people are like, what? You're so selfish, or whatever that may be. So relationships in their life could change, not for the better, but ultimately for the better if they're more genuine. Okay, moving forward. Other parts of unmasking that have been, or moving through autistic burnout, we touched on this in small group discussions earlier, but addressing internalized ableism. So letting go of what we should be able to do, or what we used to be able to do, or a certain level of functioning that we should have, change what our standards are, or what normal looks like, letting go of people pleasing, which tends to happen with masking. Um, and there's a lot of probably more depth we can go in there, but that's one aspect. And the other aspect for like deeper burnout recovery is grief work. So they're probably, if we're shifting expectations on what we are able to do or can offer or can function at, then there's some maybe grieving of the past of what we thought we could do or what we wanted to do, and some acceptance work, or being able to cope with limitations. So there is sort of a grief lens to that of like, you're not going to be able to show up in the same ways that you used to when you were over functioning because it is burnout inducing. And how do we communicate that with other people? The like letting go of disappointing others. So that's sometimes those two maybe is more of a therapeutic space kind of work that could cut across different approaches. In addition to having sensory space in the office, it's important to have that space at home. And so we can tap into sensory needs for regulation. Mm-hmm. Yeah, this is from the Guide to Neurodiversity, thinking about ultimately the principles of neurodiverse affirming approaches is honoring each client as the primary expert on themselves and their own life. So it tends to be more collaborative in the relationship, um, rather than like a specific evidence-based treat, like which evidence-based treatment is neurodiverse affirming, like it could be or not be, depending on how it's approached. But I am going to share with you the research on some common EBTs and like have they been validated in autistic population? And if so, were there adaptations that were needed to make that more supportive for that population, as well as limitations with diversity within these studies, which, as you can imagine, they're probably not very diverse. I just will say that right off the bat. So CBT has been validated in a variety of contexts. When it comes to autism, there's very few RCT level data on adapting on CBT specifically. There's one solid study that did treatment for anxiety in children with autism or autistic children. Sorry, I even wrote that there because that's how they wrote it. Again, the the like research diagnostic context is like sometimes really hard. The RCT talked about how they used coping cat, if you might be familiar with that, which is a CBT used for kids, and they did coping cat for autistic kids and found that an adapted version is really effective in treating anxiety for autistic children. They actually had a decent representation In terms of diversity, they were like the only study I found that actually addressed it in terms of like matching it to the kind of broader population, but didn't like go deeper into like different subgroups, but included, there was at least there was some inclusion there. Otherwise, it's a lot of case studies. Like it could be good for OCD, it could be good for depression and self-harm, but the specific adaptations in the child study was longer sessions with a parent component every session. So I think they did like 90-minute sessions and they met with the parents dedicated like for each session. They did more of a modular format instead of following the like in order manualized protocol. Some of that flexibility to like move around like where the interest lies or where they felt the client was. They had a separate like worked in protocol to address disruptive behavior using like reward systems. They taught social skills as needed. They did, and including in that, they did some outside assignments that were more exposure based with peers, like other kids. And they had a comprehensive reward system at home to promote motivation and treatment engagement specifically. So, not just like, oh, let's work on these skills outside, is like, go to therapy. And after therapy, you get a reward, like, which I feel like I've definitely used as well. So, these were the changes to the standard protocol that were recommended. But there hasn't been studies about adapting CBT for adults with um, anxiety that are also autistic or depression that are also autistic. So yeah, or at least that I could find. Maybe there are. Dialectical behavior therapy. Um, There's not a ton of research, but emerging research or smaller sample research indicate that DBT can support decreased suicidality and emotional dysregulation in autistic adults. That was full model. Most of the research focuses on skills training only. Um, and noted improved social communication, and that autistic adults perceived that the treatment was beneficial and supportive as well from their perspective. So again, we don't necessarily know about full model, but we know the skills can be helpful. Diversity in this sample was very minimal. So there's limitations there. Some of the modifications that were recommended included shorter treatment duration. So full metal is like 6 months to a year. But maybe, especially if we're only doing skills, we shorten that duration. Involving parents or social supports were pretty key for adults. Obviously that's built into the adolescent model. And working with, either significant others or parents, including social skills, like, or more like broken down social skills, because there is like social skills in the interpersonal effectiveness skills, but having some of that more explicit, incorporating interests in skills, visual methods, like multiple ways of teaching the skills instead of just kind of like didactics. Using a variety of communication methods for phone coaching instead of phone calls, text, emails, maybe even social media, depending. Um, and one thing that I thought was interesting was in DBT, if you're not familiar, we do a lot of chain analysis of behaviors, of like what behavior is getting in the way of your treatment or what behavior is getting in the way of your goals. And if we enact a certain ineffective behavior, we kind of look at, what are all the things that led up to it and the consequences from like a non-judgmental point of view, just for the sense of like, where can we insert skills? What can we learn? However, from an autistic lens, that's very overtly confrontational and anxiety provoking to do that. We do that in group as well as individual. So doing that in front of people. So there might need to be some work to be able to have that kind of like direct of like, here's an analysis of how your behavior got in the way. And what can we change about it? Just given the history of like having behavior be criticized or judged or shamed for being autistic. So um, we approach that more gradually, which I thought was kind of cool. And then awareness of social signaling. Um, some of this aligns with the more radically open DBT model, but I didn't specifically look that one up. So that's another option. I wanted to highlight this. So there is this book called The Neurodivergent Friendly Workbook of DBT Skills, written by Sunny J. Wise. I have this book. It's so fun. So I don't know if you've ever seen the skills manual or the worksheets in the regular classic DBT protocol, but it's like very overwhelming. There's many and they're very dense and like lots of words and not a lot of visuals. And so this one has some more like visuals. It's like a little bit cleaner, a little more open. So it kind of covers the important skills, but maybe in a less overwhelming way. Um, there's also like additional components related to sensory needs and overwhelm and meltdown. So this one is called like managing meltdowns, and it has kind of like all of these components of like creating a plan for that. There's like a sensory profile you could develop, um, support and accommodations in different areas you could develop. So it's a bit, yeah, adapting DBT to be more um neurodivergent friendly, or just anyone who would benefit from it. I feel like teens in general will benefit from this again, and it might be a more engaging kind of workbook than our traditional handouts. But I really love it. I recommend it. It's not sponsored, but you could take. It's just like on Amazon. Um, if you're interested in that. Um, Another model is parent-child interaction therapy or PCIT, and some of these could kind of translate to behavior modification, like parent training in general. But we know that this one has been more explicitly studied in autistic populations. And now kind of looking through the studies, it leads to increased compliance and improved social and behavior functioning. This is, I think, is mostly reported by parents and teachers. So kind of take that as you will, as like, what do you mean by improved functioning? And is that more of a neurotypical lens or not? And then they have modified versions for 5 to 12-year-olds. And most of these studies were done, I think, mostly with boys, but there were some with girls. And it includes increased child compliance, acquisition of positive parent behaviors, and reduction in parent reported child behavior all functioning. So I think the importance here is that like it's supportive for like parent change as well, which we know that shifting the environment can be really impactful. So the modifications for PCIT is reducing some of the punishment phase, so like reducing time spent in timeout, not having like by ignoring circumscribed interest, meaning like not trying to decrease that behavior or trying to punish that behavior. Um, Visual supports for reinforcing behaviors, in addition to the labeled praise, and doing more social stories for expected behaviors. Oh, someone unmuted. So social stories, if you're unaware, are just like these visual, kind of like here's walking through what to expect, but in a, story format. So it just like gives some kind of um roadmap as for like how might this skill look like in this environment, or what does this look like and how might you act or someone could act. So using social stories for like the behavior you're trying to reinforce, and praising social behaviors if there's some additional social challenges. So those are the PCIT modifications for autism. EMDR has several case studies and an RTC, and effectiveness was defined based on self-report from autistic clients and subjective units of distress measured in various capacities. Um, there also were findings about like what are the barriers to EMDR for autistic individuals. Well, the benefit of EMDR is that, um, hold on, yes. So here are some things to discuss more explicitly with your client if you're doing EMDR. There might be challenges with verbalizing depending on where you're at in the process or what's being activated. And so having a plan for that ahead of time. There might not be visual cues of their distress. So, like, if internally their SEDS are really high, it might not be obvious outwardly. So, just trying to be mindful of that and having ways to communicate that that isn't just you observing what they look like visually. Um, some of the internalized ableism work could be checked in on using EMDR in terms of like what events developed these beliefs and or traumas and reinforced these beliefs. So that could be a target. Also checking in about what are their visualization capabilities, because a lot of autistic folks can struggle with visualization or even have aphantasia, which is like the inability to visualize. So if that's like a primary way of engaging, what's something else that can be done alternatively? And then having flexibility in the type of bilateral stimulation. So not making assumptions about which one might be like a sensory preferred BLS or a sensory aversive BLS. So having options, kind of similar to like what does a sensory space look like? Um, Same thing with a BLS. Okay. I was like, you can hear this, but I was like, do I want to talk about ABA? What about ABA? Is it neurodiverse affirming or not? Or is that a simple question? Um, so the from a neurodiverse lens, the same intervention could be affirming or not affirming depending on how it is implemented. So there's a lot of controversy, especially lately, of autistic individuals that had ABA as kids and how traumatizing or problematic it was for them and advocating against the use of ABA therapies. And then some proponents really emphasizing the evidence base and the demonstrated improvement in outcomes, and then some challenges about like, well, what outcomes and how are those defined and who's defining them, and ABA adapting its standards based on feedback from autistic experience. And so there's like new ABA and old ABA, and like I'm not even trained in ABA, so this is just like a summarizing of like what's out there in the world. So I think there's an article about affirming neurodiversity within ABA, and that perspective is that the goals are very much individualized. And so an ABA provider can support parents in identifying goals that are affirming and highlight autistic strengths and do not punish autistic behavior. And so when thinking about that, of if a parent brings up a certain behavior that they want to change or feel like is causing difficulties in certain environments, asking yourself, like, is that behavior harming the client? Is it harming others? Is it causing damage to property that cannot be easily replaced? If not, maybe that's not a behavior that we need to focus on getting rid of or changing or shifting. Maybe the focus is more on self-advocacy or advocating for them in their environment of like, this is the function of that behavior and why it's important, and increasing acceptance around it is more the intervention or skill that we're trying to build. So the goal would be teaching self-advocacy and educating others, not necessarily fitting in. So that was kind of that perspective, but also just, we should really listen to autistic experiences as well. And so that is a summary of like, what about ABA? They, again, no research consensus or community consensus. Just do your best ethical decision making, and support families in doing their best ethical decision making and what they feel like would work best for them and their family. And that's all I'm going to say about that. Other questions. Sorry, I was trying to look through the chat. Candace just shared a resource about how to help families evaluate the quality of an ABA program. And yeah, I would say it varies program to program or even like provider to provider within the program, like so sometimes that's challenging. Any thoughts about counseling? Any adults who tried to obtain an autism diagnosis but felt their concerns weren't heard by the assessment provider. Yeah. So again, that's a lot of like kind of when we were discussing the context of them having trauma of medical systems and how to have an affirming space for them, and support them in self-advocacy if needed, either with that provider or getting a second opinion, but doing a lot of work as well in that therapy space of like processing their feelings around that and and validating the trauma around that if that's how they describe it. So, but otherwise, we can kind of wrap up. I appreciate all of you spending like half your day with me here. I appreciated all the conversations we had and the perspective shared. And um, thank you so much for taking the time. And I hope to see you guys in some other space. And have a good rest of your day.